We're focusing on these fascinating chemical messengers that really keep you alive, healthy, and alert.
We're taking a deep dive into the hidden language of the body, specifically the cardiovascular and nervous systems.
Right.
We are talking about signal molecules so small and so powerful, they dictate whether your blood flows smoothly, whether you fight off an infection, or even how you form a memory.
Okay, so let's unpack this for a second. We're not talking about your typical slow-moving hormones like cortisol or insulin.
No, not at all.
Our focus is twofold today. First, we're exploring nitric oxide, or NO, which is this universal gas that seems to act like a complete chemical paradox.
And then we pivot. We move to a stack of larger, slower-acting chemical messengers called vasoactive peptides.
And these molecules, they coordinate everything from your minute-to-minute blood pressure regulation, managing inflammation, all the way to the fundamental mechanics of transmitting pain.
So our mission today is to trace how these tiny components work together, to understand what happens when their delicate balance is lost.
And crucially, see how this knowledge has been transformed into some of modern medicine's most successful drugs.
Exactly.
So let's start with the one that feels the most impossible, nitric oxide, NO. What I find so just arresting about it is that it really shouldn't work as a biological messenger.
It should.
But it's one of the most vital we have.
It's a true marvel of evolution. I mean, what's so fascinating here is that NO is the smallest endogenous signal molecule we even know of.
The smallest.
But its identity is really defined by two unique characteristics. First, it's the only one that exists as a gas at normal body temperature.
Gas. And that means it doesn't need a receptor on the surface of the cell. It doesn't need to be packaged up into a little vesicle. It just pops out and diffuses away.
Precisely. It just floats through. And the second characteristic, this is what makes it chemically dangerous. It's a free radical. It's an oxide of nitrogen with a single unpaired electron, which makes it incredibly reactive.
So that's the paradox. The smallest, most dangerous, and most sort of ephemeral molecule is the master regulator of your entire vascular system.
That's it.
And the discovery story behind NO, it reads like a classic scientific mystery. For decades, doctors knew that certain substances, like nitroglycerin, cause blood vessels to relax, but they had no idea how.
And when researchers tried to replicate that relaxation in a petri dish, the results were just all over the place, inconsistent.
That inconsistency, though, that was the key.
It was. The aha moment really started in 1980 with Robert Furchtgott and John Zawatsky. They were studying the effects of acetylcholine, or HA, on strips of aortic smooth muscle.
And HA is supposed to cause relaxation. That's his job. But sometimes it caused the muscle strip to contract, and other times it caused it to relax. It was a complete puzzle.
And they realized the difference came down to, of all things, a simple mechanical error.
You mean how they were handling the tissue?
Exactly. Furchtgott observed that HA only caused the smooth muscle to relax if the inner lining of the blood vessel, the endothelium, was completely intact. If they rubbed that lining off, even just by accident, the muscle contracted.
So the message to relax wasn't coming from the signaling molecule directly to the muscle.
Yeah.
It was hitting the lining first, and the lining was releasing some kind of intermediary messenger.
Precisely. The endothelial cells had to be releasing something to mediate this relaxation. They named this unknown signal the endothelium-derived relaxing factor, or EDRF.
For years, EDRF was a ghost. Everyone knew it existed, but nobody could pin down what it was.
And this is where you get this beautiful scientific convergence. At the same time, researchers like Farid Murad were investigating how nitro drugs, like the nitroglycerin used for heart pain, actually worked.
Okay.
And Murad had already figured out that nitroglycerin caused vasodilation by generating nitric oxide.
And that paved the way for Louis Ignarro.
It did. In 1987, Ignarro confirmed the shocking truth. The mysterious EDRF was simply nitric oxide.
Just a common, highly reactive gas.
It was a stunning revelation that this gas was the primary messenger regulating the tone of your blood vessels. It's why Furchtgott, Murad, and Ignarro shared the Nobel Prize in 1998. It fundamentally changed cardiovascular medicine.
Okay, so that gives us the historical context and the immense impact of its discovery. Now, how does the body consistently manufacture this gas? What's the NO recipe?
Well, the recipe is actually quite simple, at least at a high level. The body synthesizes NO from a really common amino acid, L-arginine.
Okay, L-arginine.
And this process requires a specialized enzyme called nitric oxide synthase, or NOS. And you also need molecular oxygen and NADPH.
Simple ingredients, powerful results. But N isn't just one single enzyme, right? The sources really emphasize that there are 3 distinct isoforms or versions of this enzyme.
Yes, and they're regulated in totally different ways, which gives NO 3 very different jobs. It's critical for understanding its function. We can think of them as the 3 departments running NO production.
So first, we have what you could call the always-on regulatory departments. That would be neuronal NOS, or NNOS, and endothelial NAS, ENOS.
Exactly. NOS is primarily found in neurons, so the central nervous system. And ENOS is, of course, found in that endothelial lining of blood vessels.
And these are known as constitutive enzymes.
Right. Think of them as the baseline steady humming systems in the background. They're very tightly regulated by calcium levels. When the calcium concentration rises inside the cell, it activates these enzymes, and they then synthesize NO at a low uniform rate.
Which is perfect for local, rapid signaling.
Perfect. They are the immediate responders, just keeping the system operating normally. But then you have the third department, which sounds more like the emergency manufacturing plant. Inducible NOS, or IS.
The heavy artillery.
That's the one. IOS is found mainly in inflammatory cells like macrophages and neutrophils, and it is not always present. It has to be induced or turned on by inflammatory factors.
Like cytokines when the body detects a threat.
Specifically cytokines like TNF-alpha and interferon gamma, and once it's turned on, it doesn't just hum.
It roars.
Absolutely. While the constitutive forms are fast responders but slow producers, INOS takes several hours to activate. But once it is running, it produces massive quantities of NO that can last for hours, maybe even days.
And crucially, its activity is calcium independent.
Right. It just keeps running until that inflammatory signal is gone. This is essential for immunity, but as we'll see, very dangerous for normal tissue.
This brings us back to eNOS, the guardian of the blood vessel. Its primary job, as Furchgott discovered, is to cause vasodilation. And why should you care? Because NO is literally in charge of whether your blood pressure is normal or whether you're on the path to hypertension.
It is the ultimate traffic controller for blood flow. It diffuses out of the endothelial cell where eNOS produced it, and it instantaneously crosses that tiny gap to the adjacent smooth muscle cells wrapped around the vessel.
And once it's inside that muscle cell, it has to deliver the instruction.
Relax. Can we simplify that technical mechanism we saw in the sources, the NO to SGC to CGMP pathway for our listener?
Sure, let's use an analogy. Think of NO as the master key.
Okay, a master key.
When it enters the smooth muscle cell, it immediately finds and turns on an enzyme called soluble guanylyl cyclase, or SGC. This activation is the critical step.
So SGC is the switch?
SGC is the switch that generates the specific signal. It takes GTP, which is just cellular energy currency, and converts it into something called cyclic GMP, or CGMP.
And the CGMP, that's the Universal Instruction Manual for Relaxation.
That's it. A flood of CGMP then activates another player, protein kinase G, or PKG, which performs the final mechanical step. It essentially tells the machinery that causes contraction to stand down.
So NO, the key, turns the SGC switch, which makes a CGMP manual, and the manual orders the muscle to relax. The net result is the vessel expands, resistance goes down, and that is the definition of lowering blood pressure. That entire sequence, from start to finish, is the fundamental mechanism that regulates your vascular tone and your blood pressure minute by minute.
So if that system is defective, if the ENOS isn't working right, or if the NO is being destroyed too quickly, the default state of the vessel is constriction.
And that drives up blood pressure. It is a direct causal factor in the development of hypertension.
And it's important to note, right, that while this effect is most pronounced in the smallest arteries, the ones that dictate flow, NO is a general smooth muscle relaxant.
It is. It also helps relax bronchial, gastrointestinal, and other visceral smooth muscles, though its role in the blood vessel is really paramount.
Okay, so beyond controlling the plumbing, NO is also fundamental to the quality of your blood. It keeps things slick, prevents unwanted stickiness. It's a key anti-clotting agent.
Yes, it's a critical anti-atherogenic factor. Platelets, the cells that initiate clotting, they also have that CGMP pathway. So when NO reaches the platelets, it activates their CGMP cascade, which immediately inhibits the aggregation of those platelets. It's a localized do not clot here signal.
Which means if your endothelial cells are failing to produce enough NO, you don't just get hypertension, you also lose that constant brake on clotting.
Absolutely. The sources are definitive on this. Defective endothelial NO generation plays a causal role in the development and progression of atherosclerosis, the hardening and narrowing of arteries, and it significantly increases your risk of thrombosis or dangerous blood clots.
So for the listener, this is maybe the biggest takeaway. The function of your NO system is a key marker of long-term cardiovascular health.
It keeps the vessels open, keeps the blood flowing, and keeps the vessel walls healthy. It's the silent hero.
Now let's pivot to INOS, the heavy artillery, and see how this beneficial gas becomes, well, a weapon. This is the good side of that double-edged sword, immunity.
Right. So when your body detects a massive infection, that's when INOS gets induced in macrophages and other inflammatory cells. We're talking about activation by bacterial products or those powerful inflammatory cytokines we mentioned, like TNF-alpha.
And we established that INOS doesn't produce a little bit of NO, it produces huge, massive quantities.
And the sheer volume changes everything. This excessive quantity of NO is deliberately combined with other free radicals that are already present in that inflammatory zone.
To form what?
To form highly cytotoxic substances. The body is essentially generating chemical warfare agents in a very controlled, localized area.
Which gives them broad antimicrobial action.
It gives them a broad spectrum of defense against bacteria, viruses, fungi, protozoa. NO is fundamental for the microbicidal action of macrophages, allowing them to destroy pathogens they've engulfed.
So it's helping the immune cells do their job.
Yes, and it also mediates other pro-inflammatory actions, like further vasodilation and increased vascular permeability. That helps more immune cells flood the area, which is why you see the redness and swelling associated with inflammation.
But the sources make it very clear. Anytime you use heavy artillery, there's collateral damage. This massive NO production can turn disastrous for the host body itself.
And that's the bad side. The prime and most lethal example is septic shock.
Okay.
When a systemic infection sepsis occurs, INOS is induced not just locally but widely across the entire body. This leads to a massive, sustained, and pathological fall in blood pressure severe hypotension.
This hypotension is caused by extreme, unregulated, system-wide vasodilation. It essentially drains the circulatory pressure, and it's refractory to typical pressure-raising drugs.
It is a systemic collapse of vascular tone. And it's interesting to note that even though we know the mechanism, we know NO is driving this fatal drop, attempts to use drugs that block NO production in septic shock patients have not yet improved survival rates.
Wait, hold on. If blocking NO hasn't worked, doesn't that suggest we're still missing a critical piece of the sepsis puzzle?
It's a great question.
Maybe the problem isn't just the NO itself, but the overwhelming underlying inflammatory cascade that triggered INOS in the first place.
It raises a crucial question about timing and context. Blocking NO might actually be detrimental because it interferes with other beneficial NO functions like maintaining capillary perfusion or, fighting the remaining bacteria.
It just shows the exquisite complexity of trying to intervene.
It does. And beyond sepsis, aberrant NO levels are implicated in several chronic inflammatory conditions, pushing the system too far in one direction. Think of inflammatory bowel disease, IBD, where gut inflammation is mediated by NO overproduction, or even in certain types of pulmonary arterial hypertension.
And the gas is extremely short-lived, right?
Mm.
It has to be. Or those transient signals would become constant commands.
Precisely. It is extremely short-lived, with a half-life of only about 4 to 10 seconds.
That's it.
That's it. This ensures its action is localized and transient, preventing widespread, inappropriate signaling. It rapidly reacts in the blood and tissue to form stable byproducts, nitrites, which are then further oxidized to nitrates, which the kidneys then excrete in the urine.
That rapid conversion is essential. But let's circle back to that truly destructive byproduct you mentioned earlier, the one that really defines NO's fragility, peroxynitrite.
This is where the battle against oxidative stress comes into sharp focus. NO is a free radical, and it reacts extremely rapidly with another common reactive oxygen species in the body, superoxide. O2-.
And when those two meet,
they instantly form peroxynitrite, O-.
the name itself just sounds toxic.
It is a highly reactive toxin. Peroxynitrite is a devastating cellular poison. It attacks and damages virtually everything it touches. It causes lipid peroxidation, which ruins cell membranes. It nitrates proteins, altering their function, and it causes broad DNA damage.
So the balance is everything.
Yeah.
We need the NO for life. But if the cellular environment is too burdened by superoxide, that beneficial gas turns into a major tissue-damaging agent that accelerates aging and disease.
And that fragility is why the body has an integrated protective system. Our primary defense against superoxide is an enzyme called superoxide dismutase, or SOD.
SOD.
SOD is a critical enzyme because it acts as a scavenger for superoxide. By removing superoxide, SOD actually enhances and prolongs the beneficial action of NO because it prevents the formation of that damaging peroxynitrite.
So we've covered the circulatory system. Moving on, it's just wild to think that this simple ephemeral gas also acts as a primary signaling molecule in the nervous system, a neurotransmitter.
It is one of the most unique signaling molecules in the brain. It completely breaks all the rules. All the classic neurotransmitters, dopamine, serotonin, GABA, they're all stored in preformed vesicles and released in a controlled way.
Right.
NO, which is synthesized by NOS, has no stores. It is synthesized on demand and then released by simply diffusing out of the generating neuron.
So it doesn't need to lock onto a receptor on the next cell. It just floats through the membrane of both the releasing neuron and the receiving neuron.
Exactly. And often it acts as what we call a retrograde messenger, meaning the receiving neuron sends a signal back to the releasing neuron.
Okay.
In the brain, particularly in areas like the hippocampus, which are critical for memory, NO is linked to something called synaptic plasticity.
And synaptic plasticity is the strengthening of connections between neurons, the physical changes that underlie learning and memory storage. How does NO get involved there?
In the most critical excitatory synapses, activation of NMDA glutamate receptors triggers a large influx of calcium into the cell.
Oh, calcium activates NOS.
That rapid calcium influx quickly activates NNOS, releasing NO. That NO then diffuses out, strengthening the connection between those two neurons, essentially helping to cement that new memory pathway.
It's the brain's way of tagging an important connection for permanent storage. But just like in the vasculature, I'm guessing that excessive NO production is toxic.
Unfortunately, yes. Excessive stimulation of those NMDA receptors leads to what's called excitotoxicity, where neurons are essentially stimulated to death. The resulting high levels of NO and peroxynitrite are strongly implicated in this damage.
So aberrant generation of NO is seen in some devastating neurodegenerative diseases.
It is, things like Huntington's disease, Parkinson's disease, and ALS.
It seems NO is a key regulator of relaxation all across the body. The source material highlights its essential role in peripheral nerves, specifically in what they call non-adrenergic, non-cholinergic, or NANC, neurons.
Yes, and this is one of the most widely understood peripheral functions of NO. It is the established key mediator for the process of penile erection.
Okay.
When sexual stimulation occurs, NO is released from those NANC nerve endings in the corpus cavernosa.
And then the process follows that same vascular mechanism we discussed earlier. The NO causes the smooth muscle of the blood vessels supplying the tissue to relax.
Correct. That relaxation allows for rapid and massive blood inflow, filling the sinuses and causing tumescence. And the duration of this state, the erection, is determined by how long that cGMP signal persists inside the muscle cells.
Which brings us to one of the most commercially successful and, frankly, culturally significant drugs of the last few decades, sildenafil or Viagra.
It's a perfect example of pharmacology leveraging these molecular pathways. Sildenafil and its cousins are what we call phosphodiesterase type 5 or PDE5 inhibitors.
PDE5 is the enzyme whose job it is to break down that cGMP messenger.
That's its only job. So these drugs don't start the process, they don't generate any NO, but they protect the message once it's been delivered. They prevent the cleanup crew from destroying the cGMP too quickly.
I see. So they just enhance and prolong the signal.
Exactly. By preventing the degradation of cGMP, they enhance and prolong the NO-mediated relaxation signal, sustaining the blood flow needed for a functional erection. The discovery and subsequent success of PDE5 inhibitors really highlighted the profound clinical importance of this simple gaseous messenger.
It's also worth noting that NO plays a role in regulating the movement of the gut, right? Relaxing the pyloric sphincter to help with gastric emptying.
Yes, and aberrant NO signaling there is linked to conditions like pyloric stenosis, where the muscle is too contracted.
Since NO is so fast-acting and so crucial for vasodilation, it makes complete sense that we would leverage its properties clinically using donor drugs compounds that are metabolized into NO inside the body.
These are the nitrodilators, and they are absolutely foundational to cardiovascular care. The classic example is glyceryl trinitrate, or GTN.
Nitroglycerin.
Nitroglycerin. It's a rapid-acting treatment for angina, the chest pain caused by coronary artery constriction.
And GTN is often given sublingually, under the tongue, for rapid absorption and immediate action. What's the mechanism of NO release here?
GTN is metabolized by a specific enzyme found in blood vessels, mitochondrial aldehyde dehydrogenase. This enzyme cleaves the molecule, releasing NO very rapidly. Because of this enzyme's location, GTN is extremely effective at relaxing both veins and coronary arteries.
Which immediately reduces the workload on the heart and improves coronary blood flow.
Right. Then you have the slower, longer-lasting nitrates like isosorbide dinitrate and mononitrate.
And these are similar, but for more prophylactic treatment.
Yes, they're structural relatives of GTN but have a slower onset and longer duration of action. However, they introduce a really significant clinical challenge: tolerance.
I remember this detail from the sources. Continuous use can cause rapid tolerance, forcing patients to have a daily drug-free interval. Why does the body suddenly just stop responding to the drug?
Well, the current theory suggests a couple of issues. One is just enzyme exhaustion. The body runs out of the necessary cofactors or enzymes to process the organic nitrates efficiently.
Makes sense.
And two, oxidative stress. The metabolism of these nitrates can actually generate reactive oxygen species, which, as we discussed, destroy the beneficial NO as soon as it's created, rendering the drug useless. This tolerance means the treatment has to be highly regimented.
And for an emergency, for ultra-rapid blood pressure reduction in a critical care setting, we turn to the most powerful and, I guess, riskiest tool, sodium nitroprusside, or SNP.
SNP is reserved for hypertensive crises. It's given intravenously and releases NO in the blood extremely rapidly, both enzymatically and non-enzymatically.
So it causes immediate and balanced dilation of both arterioles and veins. Blood pressure drops almost instantly.
It does, but the sources flag a very serious risk here: cyanide toxicity.
Right, that's the catch.
While SNP is a fantastic tool for speed, its metabolism yields not just NO, but also 5 highly toxic cyanide moieties per molecule.
5.
So during prolonged or high-dose infusions, that cyanide byproduct can accumulate faster than the body can neutralize it, leading to toxicity. This is why SNP requires careful titration and constant monitoring in an ICU setting. It's a powerful but risky last resort.
That sounds like a heavy price for systemic vasodilation.
Right.
But there's one clinical application where we use NO for purely localized selective vasodilation: inhaled NO.
This is just a beautiful piece of therapeutic targeting. When NO is inhaled, it travels into the lungs and encounters the pulmonary vasculature. But because it's so reactive and short-lived, remember, 4 to 10 seconds, it is immediately inactivated by hemoglobin in the blood as soon as it enters the systemic circulation.
So it only acts on the vessels in the lungs and not anywhere else in the body.
Exactly. It acts as a selective pulmonary vasodilator. This is crucial for conditions where the blood vessels in the lungs are inappropriately constricted, driving up the pressure.
And inhaled NO just relaxes those vessels.
It reduces pulmonary arterial pressure by relaxing those vessels, which dramatically improves ventilation perfusion matching and gas exchange.
This is used as a first-line therapy, I believe, particularly for persistent pulmonary hypertension in newborns.
It is, and it's life-saving. It prevents the shunting of blood away from the lungs that causes serious oxygen deprivation. It's also used in adult patients with severe pulmonary arterial hypertension and acute respiratory distress syndrome. A remarkable demonstration of harnessing the ephemeral nature of a gas for precise clinical effect.
So NO is the rapid deployment force, the instantaneous gaseous messenger. But as we move from the gas to the vasoactive peptides, we're moving to larger molecules that carry slower, more sustained commands.
The shift is fundamental. These peptides are synthesized as larger, inactive precursor molecules that are then cleaved by specific enzymes to become active messengers. They don't just diffuse, they act through specific cell surface receptors, which means their effect is often more prolonged and powerful.
And as we survey the landscape of these peptides, the narrative we see is a constant, desperate tug-of-war for survival in your vasculature. We can really group them into 2 teams: the mighty vasoconstrictors and the potent vasodilators.
Let's look at the constrictors first. We have to start with the endothelins, or ETs. There are 3 forms, but endothelin 1, ET1, is the functionally dominant and most relevant one in disease.
And ET1 holds the title for the most potent vasoconstrictor known, far exceeding the power of norepinephrine or angiotensin II.
Absolutely. ET1 is produced primarily by the endothelial cells themselves, the very cells that usually produce the relaxing NO. It acts locally as a paracrine signal, causing a marked and sustained rise in blood pressure.
And how long-lasting are we talking about here?
We're talking about powerful, relatively long-lasting constriction, a sustained command to tighten the vessel. This effect is especially pronounced in the pulmonary, renal, and coronary vessels.
And in the kidneys.
In the kidneys, this powerful constriction reduces the glomerular filtration rate and urine output, which is why ET1 also promotes the release of aldosterone, contributing to fluid and salt retention.
This sounds like a system designed to just slam the brakes on blood flow and volume. So if ET1 is a powerful, long-lasting constrictor, overproduction must be central to some of the world's worst diseases.
That is the clinical reality. Overproduction or inappropriate signaling of ET1 is implicated in the pathogenesis of systemic hypertension, chronic heart failure, atherosclerosis, and most critically, pulmonary arterial hypertension, or PAH.
Right. In PAH, the constriction driven by ET1 is a key factor driving up pressure in the pulmonary circulation.
Which makes it extremely difficult for the heart to pump blood through the lungs.
So if you want to treat PAH, you have to develop a bomb squad to neutralize that ET1 signal. This leads us to the endothelin receptor antagonists, the ERAs.
ERAs are designed specifically to block the receptors where ET1 acts. There are two receptor subtypes, ETA and ETB. The ETA receptors mediate the majority of the powerful proliferative and constrictive actions.
And the ECB receptors are a little more complicated.
They are. They exist on endothelial cells and can transiently mediate NO release, which causes a fleeting relaxation.
So a selective blocker would only block the constrictive ETA receptor, perhaps leaving that beneficial ETB signaling intact.
That's the theoretical advantage of drugs like ambrisentan, which is a selective ETA antagonist. It's used to improve exercise capacity and slow disease progression in PAH patients. And importantly, ambrisentan has a generally favorable profile when it comes to liver toxicity compared to the dual antagonists.
Let's talk about those dual antagonists, which block both ETA and ETB, starting with the veteran, bosentan.
Bosentan was a breakthrough drug for PAH, but it comes with significant trade-offs. It is a dual ERA, but the sources highlight its major clinical caveat. It causes dose-dependent elevation of hepatic aminotransferases.
Liver damage.
A risk of it, yes. This risk is so significant that patients taking bosentan require mandatory monthly monitoring of their liver function tests, a massive logistical burden.
That trade-off just shows the power of the molecule we're trying to block. To tame the most potent constrictor, you need a powerful drug, and powerful drugs often have powerful side effects.
Exactly. Then there's macitentan, which is a newer dual ERA. It was specifically developed to have a much higher affinity for the receptors and a significantly longer half-life.
So one's daily dosing.
Right, and it generally has an improved safety profile relative to bosentan.
Are there common risks across the entire class of ERAs?
Yes. Two major risks stand out. First, they commonly cause anemia. Not typically due to bleeding, but due to hemodilution, as the drugs can cause fluid retention, which dilutes the blood volume.
Okay.
But the second most critical risk is teratogenicity. ERAs are highly hazardous if taken during pregnancy, requiring very strict risk management programs for female patients of reproductive age.
So we have this massive local constrictor, ET1, operating within the endothelial lining. But what molecule does the nervous system use when it needs to slam the brakes on blood flow and sustain that pressure increase?
That's where neuropeptide Y, or NPY, comes in.
Riding shotgun with adrenaline.
That's a perfect description. NPY is a 36 amino acid peptide, and it's centrally located in the fight-or-flight system. It's found extensively in the brain, but critically, it's localized in the peripheral sympathetic nerves that innervate the blood vessels.
It's the co-transmitter. When a sympathetic nerve impulse fires, it releases the fast-acting norepinephrine, which causes immediate vasoconstriction. But NPY is released right alongside it.
Think of norepinephrine as the initial burst of speed and NPY as the cruise control.
Ah, I like that.
Norepinephrine gives you the immediate sharp response. NPY causes powerful, long-lasting vasoconstriction in nearly all vascular beds, especially cerebral and renal vessels. Its effect is slower to start, but it is much more sustained. It prolongs the pressure response.
It's the backup system that ensures, during extreme stress or danger, that the increased blood pressure remains elevated to perfuse the necessary organs.
Exactly. NPY ensures sustained sympathetic dominance. It also has direct positive chronotropic and inotropic effects on the heart, meaning it increases heart rate and contractility, reinforcing that sympathetic signal.
The sources also touched on its central effects, which are fascinating, tying our vascular response directly to fundamental behaviors.
In the brain, yes. NPY is one of the most powerful central regulators of appetite. It strongly promotes feeding behavior and modulates the body's overall stress response, helping manage the physiological aftermath of prolonged stress or starvation. It acts as a bridge between central stress regulation and the peripheral vascular response.
So we've covered the gas and the constrictors. Now we transition to the vasodilators, the system's effort to balance those powerful constrictive signals and initiate repair. Let's start with bradykinin, a molecule instantly synonymous with pain and swelling.
Bradykinin is a member of the kinins family,
Yeah.
and its generation is the body's rapid response to any kind of insult. It's created from a plasma protein called kininogen by the action of enzymes called killicarines.
And this is initiated by tissue injury, inflammation, allergic reactions.
Right.
What's its triple action? Let's make this visceral for the listener. What does bradykinin do when you stub your toe?
Okay. First, it is a potent vasodilator. It causes blood vessels to relax, both directly and by forcing the local endothelium to release NO and other vasodilating prostaglandins. This rush of blood causes the visible redness and heat at the injury site.
Second, it's a profound mediator of inflammation.
It dramatically increases capillary permeability. This means the small junctions between endothelial cells open up, allowing fluid and plasma proteins to leak out into the surrounding tissue. This fluid leakage causes the classic sign of acute inflammation, edema or swelling.
And the third action is the most immediate sensation, pain.
Bradykinin is a powerful pain mediator. It directly stimulates nociceptive sensory nerve endings, the nerves that transmit pain signals, making the injured area exquisitely sensitive to touch and movement. It is the chemical trigger for that throbbing pain sensation.
So that cascade of redness, swelling, and pain is bradykinin in action. And the sources highlight its connection to a serious genetic condition, hereditary angioedema, or HAE.
HAE is a life-threatening failure of the system to turn off bradykinin. It's caused by a deficiency in C1 esterase inhibitor, the enzyme that normally regulates and controls kinin activity.
So without this crucial inhibitor, you get uncontrolled generation of bradykinin.
And that leads to severe recurrent episodes of profound edema.
That edema can strike anywhere: the face, limbs, the GI tract causing severe pain, or, most dangerously, the larynx, leading to airway obstruction.
And the ability to treat this condition hinges entirely on blocking the bradykinin signal. Bradykinin acts primarily on the B2 receptor. There's a drug, icatibant, which is a synthetic peptide that acts as a highly selective B2 receptor antagonist.
So it blocks the signal directly.
It does. It's given to patients for the acute treatment of HAE symptoms, and it effectively halts the uncontrolled swelling within hours. A stunning example of precision molecular medicine.
Now we move to the natriuretic peptides, or NPs, which are the body's ultimate internal pressure relief system. This family includes AMP, BNP, and CNP.
ANP and BNP are the critical components here. They are the heart's way of talking to the rest of the body. ANP is primarily synthesized and stored in the atria, and BNP is synthesized and released by the ventricles.
What triggers their release?
The signal is mechanical stress, cardiac distension. When blood volume or pressure is high, the walls of the heart chambers stretch. That stretching is the direct signal for the myocytes to dump massive amounts of AMP and BNP into the circulation.
So if the RAAS system, renin-angiotensin-aldosterone, is the gas pedal for blood pressure and volume retention, the NPs are the heavy-duty counter-regulatory brake that your heart slams on when it detects high volume.
Precisely. Their mission is to reverse the effects of RAAS. They have three key effects: vasodilation, which lowers resistance; diuresis, which is increased urine output; and natriuresis, increased sodium excretion.
So they flush out sodium and water.
Right. And by doing that, they directly reduce blood volume, central venous pressure, and the workload on a failing heart. They also inhibit sympathetic outflow.
This dual action relaxing vessels and flushing volume makes them invaluable in conditions like chronic heart failure. And the knowledge of how NPs work has completely revolutionized CHF treatment through the use of sacubitril.
This is perhaps the biggest pharmacological breakthrough in heart failure since ACE inhibitors. Normally, the beneficial NPs are broken down very rapidly by an enzyme called neprilysin.
Okay.
Sacubitril is an orally active neprilysin inhibitor.
So sacubitril's entire job is to keep that vital brake pedal functional for longer. It protects the NPs from being metabolized.
By inhibiting neprilysin, sacubitril significantly increases the plasma levels of AMP and BNP, prolonging their beneficial effects. However, inhibiting neprilysin alone would also affect other molecules, including angiotensin II. So sacubitril is almost exclusively given in combination with valsartan, which is an angiotensin receptor blocker, and ARB.
This combination, often packaged as a single drug, is genius. Valsartan blocks the harmful volume-retaining RAAS system, while sacubitril boosts the beneficial pressure-relieving NP system. It attacks heart failure from both sides.
And the clinical data on this combination is so powerful, showing superior mortality and morbidity benefits compared to traditional treatments, that it has fundamentally changed global guidelines for managing chronic heart failure. It just illustrates how central these peptides are to long-term cardiac survival.
We have time for one more powerful vasodilator, one that sits right at the intersection of inflammation and pain, and which has driven another major pharmacological revolution: calcitonin gene-related peptide, CGRP.
CGRP is synthesized from the calcitonin gene, and it's a 37 amino acid neuropeptide. It holds the distinction of being one of the most potent known vasodilators in the human body, even more powerful than ANP or NO.
Wow, and where's its main stomping ground?
CGRP is found primarily in sensory neurons, particularly the C and A delta fibers, and it is highly concentrated in the trigeminal nervous system, which innervates the face and head.
So its action is heavily concentrated in the head. What does it do when it's released?
It causes pronounced vasodilation, especially in the cranial and cerebral blood vessels. CGRP is released when sensory nerves are stimulated, acting as a crucial component of neurogenic inflammation and pain transmission. It is now considered central to the pathophysiology of migraine headaches.
So the theory then is that a migraine attack involves a cascade of localized nerve activity that releases a surge of the most potent known vasodilator,
Leading to cranial vessel dilation, inflammation, and extreme pain. That intense, throbbing headache is the physical manifestation of excessive CGRP activity. And just like with HAE, understanding the exact signal molecule has led to remarkably specific treatments.
monoclonal antibodies.
Yes, targeting the CGRP receptor directly. The sources mentioned erinumab. It's one of several monoclonal antibodies approved for migraine prophylaxis. These drugs are highly specific. They either bind directly to the CGRP molecule itself, neutralizing it, or they block its receptor.
And they work.
They're administered monthly and have demonstrated incredible success in significantly reducing the frequency and severity of migraine days per month. It is one of the clearest examples we have of translating peptide signaling science into a major therapeutic victory.
Just to round out the family of peptides, let's briefly touch on two others: substance P and vasoactive intestinal peptide.
Substance P is a member of the tachykinin family, which sounds appropriately fast and painful. It is one of the primary neurotransmitters for the transmission of noxious stimuli, that deep, visceral pain at the spinal cord level.
And it also mediates local vasodilation.
It does. And interestingly, substance P also stimulates the vomiting center in the brain, which is why drugs that block its receptor, NK1 antagonists like aprepitant, are widely used to prevent chemotherapy-induced nausea and vomiting.
So it's a critical messenger for both physical pain and nausea. And finally, VIP.
Vasoactive intestinal peptide is exactly what its name implies. It's found in the gut. It's a potent, broad-spectrum, smooth muscle relaxant and vasodilator produced by NANC nerves, especially in the GI tract, where it helps regulate motility and secretion. It's also involved in the stress response, but its extremely short half-life limits its therapeutic use.
Okay, let's bring this deep dive together. We started with the unique chemical paradox of nitric oxide, the gas that's a free radical, acting as the fastest, most ephemeral messenger, keeping our arteries open and ready for action.
Then we contrasted that with the vasoactive peptides, the large sustained signaling molecules. We saw this constant, hidden regulatory dance happening in your blood vessels.
This battle between the powerful, long-lasting constriction from ET1 constantly fighting the pressure-relieving, volume-flushing systems commanded by ANP and BNP.
It's a battle between constriction and dilution, constriction and relaxation, all operating constantly to maintain homeostasis.
And the knowledge of this molecular language is what defines modern pharmacology.
I mean, we've seen the therapeutic targets. Blocking PDE5 to protect the NO signal for erectile function, neutralizing the ET pathway for PAH survival, strengthening the NP signal to treat chronic heart failure, and specifically eliminating the CGRP signal to stop migraines.
This field isn't just chemistry. It's the future of targeted medicine.
It is.
And central to all of this, as we learned in the beginning, is the fragility of NO itself. Its critical role in vascular health, immunity, and brain function means its compromise has system-wide consequences.
Which brings us to our final provocative thought. We saw that NO is silently and rapidly destroyed by reactive oxygen species like superoxide, forming the cytotoxic toxin peroxynitrite.
Right.
So if the daily health of your arteries, your brain, and your immunity is determined by the internal chemistry battle between beneficial NO and destructive oxidative stress, what factors or metabolic states might shift the balance of your internal environment toward that damaging oxidative stress?
What everyday habits or underlying metabolic issues tip the balance away from the silent hero, NO? It's a fantastic, provocative thought that connects this highly technical chemistry right back to personal, actionable health awareness.
Something to mull over as you consider the hidden language constantly running your circulation.
Thank you for guiding us through this incredibly complex yet vital deep dive.
My pleasure.
And thank you for listening. We'll see you next time on The Deep Dive.